Good evening, good afternoon, good morning, depending where you are. Um, in the UK, we're in the evening. A little bit about myself first. Thank you for the introduction, Rob. Um, as Rob said, I'm UK based, so looking at UK systems. I work for Johnson Johnson. We have a small consultancy team, and I lead on the data side of things. And we basically work with health providers across the NHS and private, looking at trying to improve their performance and get a better throughput of patients. I am definitely not a modelling expert. It's something I probably more tinkered with, but yeah, I think the results are sort of vaguely interesting, and hopefully it's interesting to others as well. So we're going to talk through the situation, talk through about the patient pathway, um, what I presented to the customer. This is a piece of work that I did for a customer. They're happy for me to share it. They were happy with the output, so said, yeah, share away. I will keep them anonymized, but you know, you could probably work it out maybe. Um, Talk about how I built the JaamSim model, and then talk about the initial outputs and where we went after that. So the fractured neck and femur pathway, which is a basically hips. So older people fall over and they break their hip. They usually end up in the emergency department. NHS in the UK is free at the point of delivery, so for emergency care certainly. But the pathway is funded through the NHS, so there is a tariff that the providers will get for the A&E attendance, and then when the patient is generally admitted and has surgery, they will get a further tariff to the representative of the care they receive. There is a second part of the tariff, which is for what they call best practice, and there's 7 elements that they have to hit to get that best practice tariff. Um, they include being seen by a geriatrician within 72 hours, being assessed by a physio. There are things about mobilization, dietary requirements, but the one that's the real sticking point is from arrival in A&E to having your operation to have your hip fixed. It needs to be within 36 hours. There's a lot of clinical evidence that suggests that that's a really good thing for patients. There is much better outcomes under that 36 hours than as soon as you go over that. So if you get lower, great, but 36 hours is where they've set their line. So the question asked was, could JaamSim be used to highlight pinch points and try and focus on areas of improvement for the customer? So the pathway kind of simplified looks like this. You've got, arrival in ED. You get an initial ED assessment. You would then get to a ward eventually, go into the operation theatre, and you probably go back to the ward. A small proportion of patients, and it's relatively consistent, go back from theatre back to the ward and have to go back for a second operation. It's somewhere around the 5% mark. But the bit that needs to be less than 36 hours is that from that ED arrival to that operation in theatre. So other things, it's not just fractured neck and femur pathways, patients that go through on the same pathway. There are other patients that come through on the same pathway coming through A&E. Of particular note there are other trauma patients, so other patients who've had falls or they've had accidents and they've broken bones, need to be fixed. So those trauma patients tend to get lumped together with the neck and femur patients. The particular customer had 2 theatres, which they scheduled to have different opening hours, and they had different opening hours based on day of week as well. And the patients won't all go to the same day. If they arrive on the ward past about 2 or 3 in the afternoon, there's not time to get them through to theatres. So they will be held on the ward. So, and for the purpose of the model, we felt we didn't need to follow the patient once they'd left the theatre. They do go back to the ward, but it wasn't seen that the capacity on the ward was a particular issue. It was the time getting into theatres. So we excluded that for simplicity. So a JaamSim model. So you can see there's 3 theatres, theatre 3 switched off. You've got the 2 different types of patients. You've got them coming in, they get to the ward, they go to a theatre, they leave the model. And we'll come through a bit more of how that looks in JaamSim without everything hidden. So really lucky in the NHS that we're really data rich. So The customer is able to provide a decision points, and then I spent some time with our fitting distributions. So looked at the arrival distribution, ED duration, operation duration, and the operation rates. And then we used a support decision to treat and off patients and other trauma patients as distinct cohorts of patients. You kind of work that way in the way that the data is set. So you can see we've got some lovely Weibull distributions. Not bad fits, not bad fits. Slightly better fits on the operation, the trauma patients. So that's where we went. In terms of what the JaamSim model is, so you've got we set up your two types of patients, and we set them up with attributes, so we were able to track different points through the way. As was mentioned yesterday, there's a need to initialize the system, so wards are not empty when you turn up in the day. So we also generated a starting state for the ward, which had a number of patients on there that sort of was representative of the number of patients they were seeing on the ward. We went with different flows, traveled different routes through A&E, just because it was easy to set it up. For the patients arriving later, we basically just chucked them around a little conveyor belt, so they got stuck to the ward after the theatres had closed and the theatres had open times. Assigned some attributes to the patients and had different exit points, so that when I was doing testing, I was able to set up some live reporting so I could see what was happening and just try and debug my code a bit better. I'll just pause there just to give you a chance to have a look through. So model was doing more or less what we expected with single runs, but and the output was in the expected range of historical performance. Clearly, as you've seen, one run isn't enough, so we set the seeds of the distribution to be linked to the run number, ran through the model 1,000 times to run for a year, and then we threw the data out into a CSV file and put it into SQL Server. I've got a background in SQL, so I find using SQL easier to process the data. I'm sure you could use other tools. You could potentially even throw it into R or something like that. So output distribution gave us a distribution. So went to the customer and said, yeah, this is what it looks like. That's where you sit. That's where they sat for a particular year, which was the baseline year that we had the data on. So luckily, the customer had a statistical background. He was happy that was reasonable. He thought that was reasonable. We went through all the assumptions, went through all the details, and he was happy with that. So it didn't necessarily have to be. We didn't expect to be in the middle. Well, I didn't expect to be in the middle. It's a distribution after all. They were coming from a period where in previous years they were at 30%. So they were happy that they were moving up through the percentages, and they looked like their capacity they had gave them the ability to get to 65% around that figure with existing resources. However, the great thing about JaamSim is gave us the data to really dig into it, and unsurprisingly, the time in ED became a really key factor. And you can see, just for a straight line across the top, you can see it really starts to drop off unsurprisingly as you get towards part 13 hours, 14 hours, and really starts to drop down to 24 hours because you just don't have the time after going through A&E to get into theatres. And then we identified issues with the system. So things like there appear to be issues where if you get multiple arrivals in a day, and then cases where you had more than 6 patients on a ward at any one time waiting for a hip fracture, then it started to think that actually really good metrics there for an escalation policy, because the operational teams on the ground can go, oh yeah, that's the 3rd hip fracture we've had in the last 24 hours, or oh yeah, on the wall we've got 6 patients, and they can put steps into place to really look at that amount of capacity, amount of theatre time they've got, potentially bring in extra consultants the next day to try and clear the backlog, or can you potentially extend the theatre session as a one-off for that day just to make that capacity. NHS in the UK really limited in resources. There's not much not much available to make changes. But the great thing we had is we could look at each individual change. There were options. So they looked at extending the theatre timetable, whether they're doing extra sessions at the weekend, where they had slightly reduced sessions, or a slightly longer day, reducing the time in A&E, and we could try and quantify the change. So potentially we looked at sort of reducing A&E time by about a couple of hours, which might not be achievable for some of the earlier patients, but it was a something we could look at, try and fast track the fractured neck and femur patients through. And potentially there was a scope for a sort of 20 to 30% increase in the best practice tariff, which, considering the best practice tariff's worth about £1,300 per patient in the UK, it's quite a significant amount of money when this trust having sort of 600 to 700 fractured neck and femurs pass patients through each day. And that's all I've got to share for you, really. I'm happy to answer any questions you may have or talk through anything else. Any questions?
Thank you, Matt. I'm going to allow people to type their questions or unmute themselves and jump in. I've got a question, but that's I'm going to give the opportunity to let someone take a shot.
Do you want to ask your question? Then it might trigger.
All right, yeah, maybe I should just go ahead. Would you mind pulling back up your presentation, please?
Yeah, just give me a second because I've just stopped.
Certainly.
Which slide was it you were after? The
one, let's just do the big overview of the model, please.
Yeah, sure. Share that screen. I'll just do it like that. Just that. I'll do that again.
So I had kind of two questions. You brought up a great point about sort of a model initialization period in terms of, the ward isn't empty, it's a 24/7, 365 operation. How did you run your scenarios with a different, assuming there's, two people in the ward versus 10 people? Was that one of your initialization variables, or how did you handle that?
It wasn't. We didn't set that up as a variable. That's an interesting idea, actually. No, so we knew what the ward occupancy was, and we knew roughly how many patients were generally coming through on that on the pathway, and it was just a decision.
So you looked at
it wasn't something
data.
considered. Yeah, looked at historical data, looked at historically how many people were generally waiting. But yeah, it would be interesting to run some different variations with plus minus 1, 2, 3 patients on that location. But yeah, it wasn't something that was sort of fed back by the customer that they sort of went. They didn't say that. Oh, have you thought of that? And yeah, unfortunately, I sort of work on my own in this particular space. So yeah, no one else sort of came up with it.
Okay, and I got one more question for you. So I know that through I'm not in the medical field, and I have not been, and I know that when governments and healthcare providers kind of set up a big complicated healthcare system, there's often they don't want to overbuild their resources, but they I think they try to focus on utilization and stuff like that. And I think during the COVID pandemic, we kind of learned that all of a sudden you have this huge spike and you don't have enough equipment for equipment for all the needs, or theaters or operating rooms or what have you. And so, in your model, you're not talking about respiratory, COVID stuff. You're talking about like hip fractures. And, recently where I was, we had a lot of snow and ice. And I would imagine that you could potentially have more people slipping and falling and breaking their femurs. How do you handle unusual periods of unusual need? Are you able to go back to historical data and saying, well, this day was unique, but we had a big snowstorm. We had a lot of people falling, or something like that.
Yeah, yeah. There's a lot in the press that say you get more patients. The actual variation you seem to get when you get that snow and ice isn't sort of outside the normal sort of random distribution you tend to get,
Okay.
at least from what I've seen. Um, yeah. And so I think in terms of resources, that's why we added three theatres in the model, because one of the questions was, if we added another theatre during the day, would that help? And the answer was no, not really. Um, so they were trying to, they had more capacity that they could potentially have allocated to the fractured neck of femurs, but they didn't really want to, because they felt that the time that they were using wasn't being particularly well used. Some of the things we looked at with the model spitting out was actually what percentage of of theatre utilisation, what was the percentage theatre utilisation time. And again, non-elective theatres, it tends to be slightly difficult to measure, because they're normally open from sort of 8 in the morning till 8 at night. So you end up with a very long period of time, which you wouldn't expect to be operated on continuously throughout. So sort of 50% for a non-elective theatre that's set up like that is not uncommon, compared to your elective theatre, which you'd probably be looking for 85% plus in terms of sort of what you're trying to use. And in terms of materials, sort of relating to your question, that it wasn't, because it was a large hospital. It wasn't something that it was even sort of worried about that they had sufficient sort of material and spare hips and devices to be able to use to treat the patients.
So we've got two questions here. We've got one from Anthony Earl. He asked, "Is changing the seeds necessary for each replication?"
Um, yes, I believe so. Please correct me if I'm wrong, one of the experts. But yeah, if you run it with the same seed, you're going to get the same answers from all your distributions. So I just set the seed to a variable based on the run number of the simulation. So yeah, with my 1,000 runs, I basically run number plus one, and for each of the distributions I had a different seed. So I believe it is. If you don't, you get the same answer each time you run it, which wasn't the intention. But yeah, please, if one of the experts want to clarify that, please jump in.
All right. And the next question from Harry King was, "Did you use the run outputs list to select the results for analysis?"
I believe, sorry, a little while ago I did it. I believe I just pushed everything out. So I get data points, I think was on the thing. And then yeah, just put the output to a text file, and then just use SQL to drill into that and work out what it was that I wanted to use to measure and identify the patient. So from that I could identify which run number, which patient number, and all the various attributes. I think that covers it.
So, Matt, and congratulations on your model. It really does look very nice. You've done a good job.
Thank you.
My question was were you using just the main output report from JaamSim, which is pretty long and hard to parse, or were you specifying specific outputs that you're interested in this run output list input, so that then you would get a table. It would spit it out in tables with each row being for each replication.
No, so I pulled out every patient within. So I just passed the whole file. So I just wrote a SQL Server Data Tools package just to pull in the file and store procedures to process it. So yeah, it took a little bit of figuring out, but
if you're
it's relatively well structured in terms of how how the data is laid out, So I had a record for every entity that went through the model.
Yeah, so that sounds like you used a log file to entity logger to prepare a output file for each patient.
Yeah, I think it was just one output file that covered every patient.
Yeah.
Apologies, I should go back and check that. Happy to answer.
Anyway, hey, what you did work just fine. I just thought I'd offer some coaching on possible ways to do things easier, or
Yeah,
what you're already doing it that way. We can talk after the conference if you're interested in
yeah, definitely interested.
some coaching on or if necessary even on your model.
Yeah, thank you. That'll be
Nice
appreciated.
it's a very nice project.
Thank you.